So he's going to talk on outcomes and comparison of retinal autograft using FINESSE flex loop in failed macular holes. And the discussant is Ellen Kumar.
Hi, should I start? Hi, good afternoon. So I'm going to be talking about the outcomes and comparison of the retinal autograft using the FINESSE flex loop in failed macular hole cases. So we know that the iLM peeling has become the gold standard for doing any macular hole surgery, and just a plain iLM peeling guarantees 80% success rate. And if you do the conversion of the iLM peeling with the inverted flap technique, we get a 96% success rate. But we still have about 4 to 5% cases where we do fail. And some of the techniques that we've been doing for these failures is we regraft reuse the iLM, we use autologous products, anterior capsule of the lens, fibrin glue, or we use autografts as the retinal or the choroidal. So our focus is going to be on the retinal autograft, that is for using managing these failed macular holes. Till now, we have been introducing localized retinal detachment and using intraocular scissors to obtain a retinal autograft. So our first innovation was that we published it also. We used the FINESSE flex loop, which is being used to scrape the iLM. We used it to obtain the retinal autograft itself. This was a retrospective study design, and we had all patients with failed macular surgeries or in a patient with any subtotal retinal detachment with a macular hole. So primary outcome was to evaluate the anatomic and functional closure of the hole with the retinal autograft. So this is any macular hole, this is the OCT picture, and this is the autograft picture. And then we do the surgery, we do a cautery, and just with the FINESSE flex loop, we scrape the edges of the autograft to obtain one whole piece of the retina, which we use to fill the macular hole, as on the OCT picture on the right side. So our results, we had 8 patients, 75% of 6 eyes were just plain autographed eyes, and 2 cases were with retinal detachment. We observed a post-op macular closure of 75%. When we looked at the post-op visual acuity gain, we saw 1-line improvement in all of our cases, which was statistically significant. And the only complication we saw at 6 weeks was the post-operative was the graft shrinkage, which happened about 2 eyes. So knowing this, that our technique was working, we compared our technique with the pre-existing intraocular scissors and with the retinal punch that was defined by Dr. Rupak Roy to compare our results with that. And this was again a multi-centric analysis of all the failed macular holes. 6 surgeons were involved. The primary outcome was same for analyzing the closure of macular holes and the reattachment of the retina. And secondary outcome was to see if there is any restoration of the foveal contour or any integration of the graft of the inner and outer retinal layers on the SDOCT. So in results, we saw we had 22 eyes. We had ARG done in 16 eyes and ARG and RD done in 6 eyes. And the preoperative diameter of the macular hole was around 1100 microns. And we used gas in 15 cases and oil in 7 cases. With all these cases, we obtained a macular hole closure about 72.7%, and visual acuity was actually increased to 81.8% of these cases. So, and when we compare these results as in comparison of visual acuity in all 3 scenarios, we saw that the FINESSE flex loop and the scissor was able to give us a good post-op visual acuity, which was statistically significant as compared to the retinal punch. But when we come at the restoration of the outer retinal layers, we realize that the retinal punch was giving a much more greater restoration of the outer retinal layers rather than the FINESSE loop and the intraocular scissors. And the complication was equal in all the groups. We had a graft shrinkage in all 3 groups. Only a dislodgement of the grafts was noted in a case where oil was used and there was a complete graft loss. So in conclusion, ARG can be an effective surgical application for large failed macular holes with or without retinal detachment with good functional and anatomical outcomes. Statistical visual gain can be expected after autologous retinal graft, and our study concludes that both FINESSE loop and intraocular scissors offers good retinal outcomes, and retinal punch was associated with more functional outcomes and more graft shrinkage. Thank you.
How many cases you said 8 cases you did this?
So initially, first study was 8 cases.
That first picture, no, that you are talking of this 1100 is
the second
minimum
one,
linear. Second is with RD.
No, this is the one just plain macular, failed macular, sir.
Failed macular.
The RD ones we didn't really get to measure the macular so much.
Okay. So that is the second. The first case you that showed, no, that macular hole has cystoid changes and that configuration. We just with FA and
so we already tried.
Close.
So he was already operated thrice somewhere else.
That one.
Thrice was already operated. 3 ILM filling was done.
Because we did some analysis of 700 macular holes. Just usual standard ILM peeling closes 80 to 85%.
That's why he already had 3 cases. Then we thought
that is a failed one. That's a failed one. Showed. Okay. Unless there is a randomized trial, no.
No, you said you are using finesse loop,
Yes, sir.
but in your video it is not shown.
Yes, it's shown, sir.
Oh, okay. Do you use a PFCL when
No,
you're
sir.
No.
No, sir.
But in case if the retinal graft flips, instead of seeing the
So
outside
we-
world, they will start seeing the brain. How will you prevent that?
No, sir. We actually do a cautery around the autograph, so
Okay.
the cautery mark is very much visible. So we just gently drag with the forceps, we just drag it and put it on the macula itself. We don't make any intraoperative changes at that point in time, so that the fluctuation will cause the graft to move away somewhere.
Okay. The last question. What is the innovation in this?
So the Finesse flex loop, it's not been used for obtaining retinal autograft. That was we are the first ones to use the Finesse flex loop for obtaining retinal autograft. As per the Alcon, they only use it for iLM peeling. We've been using it now. We have about 12 cases. We've been using the Finesse loop with no localized retinal attachment and just autograft.
Dr. Abhinav, for non-retina specialist, you should have told us what is Phoenix Plus. We have no idea.
It is used to peel the ILM also.
Just to scrape the retina.
Just to
sir,
raise the
ILM
edges.
layer.
It's a brush. Instead of scratching our back, we can scratch the retina.
Very good sense of humor, Naresh Babu, sir. Always typical Naresh Babu.